All right, it's about 3:01, so for the sake of time, let's go ahead and get started. Welcome everyone to our first Fellows Case Conference of the year. By way of introduction, my name is John Huang. I'm currently a fellow at Emory and a member of our Training and Educational Work Group leadership. Before we start the conference, we just wanted to have a very brief introduction to the purpose and format of the conference. And so I would like to start by thanking and highlighting this collaboration between IDSA, our Fellows Community of Practice, our Training and Education Work Group, as well as CPSolvers. So thank you for everyone that helped to put this together, and we're really excited to present this as a group. This slide really just to introduce the group and kind of the main participants. First, an introduction. For those that are not aware, IDSA is our leading medical organization dedicated to connecting our ID community, advanced science, advocate for equity. And recently, we've been able to expand our Fellows Community of Practice, which has been a formalized way to support ID fellows across the country and even internationally for the purposes of engagement, education, and professional development. At the bottom, I just really wanted to highlight our amazing training and education work group. I think the major things I just wanted to point out is the diversity of people, the practice settings, different academic centers, people from across the country that really help to make this work group possible and really help to improve and collaborate in terms of education efforts for all ID fellows. And so we're really excited to have this group newly made this year, and we're excited to have more participants, hopefully more volunteers join in the future. And lastly, just before we start the case conference, I just wanted to go through briefly the learning objectives and highlight some of the main participants and expert discussants that we'll feature today. In terms of learning objectives, we're really here to focus on fostering an open clinical reasoning-oriented case discussion amongst ID fellows and other trainees, so whether that be students or residents or attendings. We will also love to learn from our experts who are clinical experts in clinical decision-making and really highlight their approach to an unknown case. And lastly, this is meant to be fun and collaborative, and so there'll be opportunities to meet your peers and have fun as a group. During the conference, we will also employ some breakout rooms, so just so you're prepared, there'll be a very directed task for the breakout rooms. We understand that this is 3 p.m., people are on service, people are busy, but as best you're able to try to collaborate and kind of foster some discussion amongst the group. Over here on the right side of the screen, I just wanted to highlight our presenters. Our case presenter is Wasim Abdullah, a former Emory Fellow turned assistant professor here at Emory. And our CPSolvers liaison is Yusuf Saklawi, who is an assistant professor and a Grady hospitalist, who again represents the CPSolvers. And along with him is Sarah Blaine, who is one of our fantastic medical students who will serve as our scribe. In terms of our faculty discussants, I think these two need no formal introduction. Everyone is very familiar with their expertise in clinical decision-making. But we have with us Dan Minter, assistant professor from UCSF, and Varun Fadke, associate professor of medicine at Emory. And so with these introductions, we're really excited to have all of you amazing folks join us for this case conference, and we look forward to more case conferences throughout the year. And with that, I'll go ahead and turn it over to Yusuf to get us started. Stop share.
Yeah, thank you, John. And John was my chief resident. I always look up to John every time. Thank you all for being here. Happy to be here. Wasim, if you're ready, we can go ahead and start with the case. Then Wasim's going to present, and then I'm going to ask you a few questions, and then we can go ahead. So whenever you're ready, Wasim.
Awesome. Thank you, Yusuf. Thank you, John. Thanks, everyone, again, also for joining us. So today I am presenting a case of a patient who as a chief concern, had fever and rigors. That was the main complaint. Now I'm going to give a bit more information since this chief concern is not very specific. So this is a 62-year-old male who presents with, as we said, fever and rigors. And of note, this patient presented initially to the emergency department. And in the ED, the patient had severe leukocytosis. I guess not that severe, it's like 17,000. Blood cultures were collected, and they came 2 out of 2 Streptococcus sanguinis. Ceftriaxone was started. The patient felt better. The fever and the leukocytosis resolved. And that's not all, because if that was all, we wouldn't be presenting this case here today. So a few days later, the patient, while still in the hospital, started to have a new fever up to 39.5 almost every day. The patient didn't feel well overall, but didn't have much specific symptoms or pointing symptoms or localizing symptoms, except for a mild cough that was non-productive. Specifically, he denied any runny nose, sore throat, nausea, vomiting, or abdominal pain. No dyspnea, rashes, dysuria, but he does report some night sweats. Of note, this is happening in March, so in the month of March. And yeah, that's kind of it. I'll give more information after. Dan, obviously feel free to like interrupt me, or if there's any piece of information you'd like to know, but if not, I can continue with like some of past medical history. What do you prefer?
Yeah, I'm happy to comment now. And thanks so much, Wasim and Jonathan and everybody. You know, both of these groups, CPSolvers and the IDSA Fellows Group, are near and dear to my heart. So really an honor to be invited here to chat with you all, with Varun as well. So I a couple of things, you know, I love fevers. Fever is very fun, you know, chief concern in ID, and certainly something well within our wheelhouse. So I kind of think of it as like a gateway symptom into, you know, a broader conversation. I'm sorry, it seems like maybe somebody might be unmuted. So thanks, Youssef. But anyway, yeah, fevers is kind of like it's so non-specific, it's often something of a gateway chief concern into, you know, a broader sort of diagnostic workup. And I always try and think of, you know, fevers and something else to get a little bit more specificity. You know, the interesting part with this case so far is that it sounds like, you know, the strep sanguinus and, you know, maybe was the likely cause of the initial fever, but now several days into our course, we're having, you know, a recurrence of fever or perhaps a different fever. I'd say just to briefly talk about the first element of this case being, you know, strep sanguinus bacteremia. 2 out of 2 sets of blood cultures with strep sanguinus makes me think that it's going to be likely a true positive. And the question with strep bacteremias is often, you know, is it just like an uncomplicated strep bacteremia or something more complicated? Like, are you looking at just, you know, the part of the iceberg that's above the water or something kind of lower down underneath the surface? So within strep species, I sort of divide it into like pyogenic strep, like group A strep, group B strep. Those are often like skin, soft tissue sources. That's the first group. The second group is strep pneumo, which is like of historical importance that it's, you know, such historical importance, I keep it apart. And then the third group is going to be like Viridin's group strep and strep bovis. And I kind of think of Viridin's group strep as like that person from college who you maybe sort of recognize. Like if you understand that it's a strep name, but can't quite place it, it's probably a Viridin's group strep. And the reason that those are important is that there's a whole bunch of them, and they often form part of our microbiome and can, you know, sort of be in your blood for a while, and as a result have some metastatic sites of infection like endocarditis. So strep sanguinus is one of the ones you'd worry about endocarditis for. So I'm interested to hear what other sort of diagnostic workup comes up with this patient. You know, do they get a transthoracic echo? Do they get a transesophageal echo? And does that play into our case later on? So that's like part one of this case. And Wasim, sorry, how many days into the course did the second set of fevers occur?
So the first, you know, obviously patient presents to the ED with fever, has fever maybe for like 24 to 48 hours at the beginning, starts it on ceftriaxone, things looked like they were heading in the right direction, fever goes away, and then maybe like 4 or 5 days later, this new fever happens. So like there were like 3 or 4 days of no fever.
Okay, gotcha. That's really helpful. So I think an approach at this point, you know, is, you know, considering whether it's related to the initial sort of disease, you know, is this a complication or some sort of effect of something that we're doing as part of either, you know, the treatment for the initial strep sanguinus bacteremia, or, you know, is it like a complication down the line from, you know, does he have endocarditis? Is there something else going on? Or is it like totally unrelated? So is it like a separate concurrent infection that we didn't identify at the beginning, and strep sanguinus, you know, although present, maybe was, you know, true and unrelated? Or is it, you know, like a new onset, like nosocomial source of infection? So I think with something like this, I would do my general sort of, you know, anatomic check of like common sites of nosocomial infections, on exam, do they have evidence of a new pneumonia in the hospital? Do they have evidence of like a GI illness? Did they develop, acute cholecystitis, pancreatitis, or something like that? Do they have a urinary tract infection? If it's not symptomatic, then I think that that's probably unlikely. Or do they have like a skin soft tissue infection? I think, being relatively humble and keeping a broad differential at this point makes a lot of sense. I would also be interested in their social history to see if like there was a concurrent separate infection that, had they just been like mountaineering, got, bit by a bunch of ticks and stuff. I don't live in a part of the world where there's a whole lot of tick-borne disease, so I was wondering if that's something that you guys might be worried about over there. But it's sort of just going down and doing your good general ID history taking to see if there's something else going on. So maybe, that's a lot of stuff. And I think that this case could play out in a lot of different ways, but maybe I'll stop there and, say that I'm interested about, social history. I'm interested in the results of your initial workup. And, I would solve the case or the question of, does this patient with strep sanguinis bacteremia actually have like underlying endocarditis or a more complicated infection than may initially appear?
Perfect. Thank you, Dan. This is very helpful. It's also good to kind of see this initial ID, like doctor's approach to fever. It's very good. So let me give you a bit more information about this patient's past medical history. So this patient has a history of lupus, and that lupus got complicated by end-stage renal disease. So in 2011 or 2012, this patient got a renal transplant, but then that was rejected a few years later. So 4 or 5 years after the transplant, there was an episode of kind of continuous and progressive graft failure to a point where the patient, 5 months prior to this presentation now, this patient was back on dialysis. So through a left AV graft. So there was a fistula first, and there was also a graft that were placed. There was an issue with the fistula, so they end up using the graft. This patient also, just kind of to give a bit of a context, this patient over the last like 8 months has presented to the hospital multiple times, every time with kind of like a fever or an infectious syndrome, but they were all kind of very different. One of them was an E. coli bacteremia. The other one was flu. The third one was a rhinovirus episode of upper respiratory infection. So there were, separate events, but this patient has been having issues over the last few months. This patient also, speaking of, you were talking about endocarditis, this patient has a severe aortic regurgitation history and has had a mechanical valve replacement also around 10 years ago. The third thing is this patient has a history of bladder cancer that is in remission currently. Had a TORB done, an intravesical immunotherapy that was around 2019. So around like 4 years before this, or 5 years before this episode. So this is kind of like the main past medical history. I'll add, some of the home meds that this patient is on, and I think that's kind of also interesting. This patient, despite the fact that there was a complete failure of the graft, but this patient was still actually on prednisone and tacro, and the reason was to avoid hyper rejection. So there was a conversation happening between transplant teams talking about like how to kind of wean him off of immunosuppression. So he was still on prednisone 10 milligrams, tacro 1 milligram daily, warfarin, and nifedipine. Those were the meds that the patient is on. Family history, the patient has just common disease in the family, diabetes, hypertension. And since you kind of spoke about social history and asked about interest in what kind of social history we have, I'll add those and kind of and then get back a little bit to you, Dan. So this patient works in a computer store in Georgia. He is from Georgia, so native from the state of Georgia. Has not really traveled much overseas, but he was in the military and has traveled in that context to Belgium in the 1990s. No recent travel or hiking, no pets at home, no homelessness, incarceration, or really any of the typical risk factors for TB, sexually active with his wife only, and doesn't recall anyone sick around him recently. So I guess I'll stop here for a second and kind of see, and allergies, no allergies that this patient is aware of. So any questions that you, like any other things that you would like to know, Dan, before we proceed to kind of physical exam and the initial workup?
Yeah, I had, I guess maybe as the background for this question is, now we're sort of shifting our frame into this being a patient who's a solid organ transplant recipient who's coming in with, an infectious syndrome, or multiple infectious syndromes potentially. And one of the important things in terms of like gauging the risk for different infectious syndromes for transplant recipients is, kind of what's their net state of immunosuppression, and then what is their sort of nature of their exposures. And classically, the way that we talk about it is, in the absence of rejection, there's kind of three very sort of well-trodden timelines. It's like the first month after transplant, your immunosuppression hasn't fully kicked in. You're often still sick in the hospital. So numerically, like nosocomial infections are going to be a little bit more common than opportunistic or reactivated infections. Whereas in the middle post-transplant period, like a month to 6 months or a month to the first year, then that's kind of when your immunosuppression maximally kicks in and you can reactivate different infections, whether it's TB, histo, cocci, stuff like that, that could happen when you are more maximally immunosuppressed. And then following that, then you are still immunosuppressed, but kind of less so than that middle period, and you're going to be mostly at risk for community-acquired pathogens. So the idea of this patient coming in with E. coli bacteremia, with flu, with rhinovirus, that's kind of a pattern of like, you're out in the world, you're back home, maybe you're interacting with, grandkids or kids and stuff, and you get sick for other reasons. That timeline does reset though, if there is a clinically relevant episode of rejection. And so you told me that, this graft has more or less failed at this point, they're back on dialysis. But my question to you is, as part of that transition back to dialysis, did they get treated for rejection within the past year, past 2 years? Like what was the sort of augmentation of their immune suppression around that? Because that could be relevant to the sort of things that we might be considering.
So yeah, that's a great question. So this patient initially, but that was years prior, so not in the last year or two, there was obviously trying to preserve the graft as much as possible. So there were treatments with high-dose steroids and whatnot for transplant rejection, but not in the last year or 2 years.
Okay. And then, I think that kind of factors into a couple of things that caught my eye. So you mentioned the bladder cancer with, intravesical immunotherapy. So I assume you're talking about intravesical BCG.
Correct.
So oftentimes, intravesical BCG, it's like the laboratory passage of, bovine Mycobacterium bovis that then elicits reaction against sort of superficial bladder cancers. And most of the time it like doesn't cause problems, but some percentage of the time you can get disseminated BCG or locally invasive BCG. So you could get like prostatitis, epididymoorchitis, BCG in the local lymph nodes, or on occasion it can escape the bladder and then basically cause, a disease similar to extrapulmonary TB. And it's something just always to kind of have on your mind when somebody's had intravesical BCG. And, as a first-year fellow, I think we had a case where it ended up being like spinal disease, and the person who had like, essentially no TB risk factors, but it sort of, ended up being Mycobacterium bovis as a result of dissemination from BCG therapy. So that's just like one of the things maybe I put a little asterisks around in my head.
Yeah.
I'm not sure if the timing works because this seems like 2 years ago. Those often happen kind of earlier after the initial therapy. And then if there hasn't been a ton of augmented immunosuppression, I think the likelihood of like clinically significant reactivation is probably a little bit less. But anyway, so we can maybe come back to that depending on how the case shakes out. I will say the other thing that's notable is this prosthetic valve. We're ID doctors. We talk about endocarditis all the time. If you have a prosthetic valve, that's definitely something to worry about, especially if you have a bacteremia with a pathogen that's higher risk for infective endocarditis. So My initial concern for endocarditis is augmented further. That doesn't necessarily explain why like fevers went away and then came back. But, I think at baseline, it's hard to move diagnostically forward a ton before exonerating the idea of endocarditis. And how could we do that? TTE is going to be essentially useless in somebody with a mechanical valve. Still get it first just so we can convince our cardiology colleagues to go for the TEE, but TEE is not going to be particularly sensitive either. This might be a case where you could consider like a PET scan or something like that. So I'd be interested in that workup. Just trying to think of other things, maybe I'll hold my thoughts on like alternative sites of infection until we see a little bit more from the exam and the laboratory evaluation. But I think that their transplant recipient, even though it's rejected, they're still at high risk for a lot of different sort of sites of infection and atypical pathogens.
Right. Thank you so much. This was like a great approach, taking consideration all of the past medical history and special risk factors that this patient has, and a setting of like fever where it could be anything. Perfect. So I'll give a bit more, physical exam and some of the basic workup that was sent initially. And obviously in that setting, a transplant ID team was consulted. So the patient, obviously there's the fever in the vital signs associated with a tachycardia around 110. Blood pressure was 150/80, respiratory rate of 18, and setting at 98% on room air. Other than that, really physical exam was not localizing to any cause of this fever, I would say. So that's from a physical exam findings, other than patient just feeling uncomfortable whenever the temperature is high. The basic workup, so as we said, initially on the white blood cell count was 17,000, but then once ceftriaxone was started, the white blood cell count nicely went down to normal, and then even when the fever came back, the white blood cell count did not go up again to the 17,000. It was around 9 to 11 throughout his stay in the hospital. And with the differential, that was neutrophils majority, and there was no eosinophilia on it. Other than that, hemoglobin was 8.7, which is lower than his baseline, around 10. And the platelets were 300,000. Sodium was normal, potassium was normal, chloride really like BMP was normal. His LFTs, he had a mild elevation in his AST to 107, ALT to 89, and then ALK-Phos 213. He had a ESR of 69, a CRP of 106. So that was like during the time of fever. There was no baseline to compare to. The complements, the C3 was 95, the C4 was 35, within normal limits. Double-stranded DNA in this context of him having lupus came back within normal limits as well. And obviously, a lot of repeat blood cultures were done in that setting, trying to see if the strep sanguinus comes back. And all of those repeat blood cultures continued to be negative throughout, at least like in the phase of initial workup.
Thank you, Wasim. I think for the next step, we're going to pause and create breakout rooms. If you all can just introduce yourselves, discuss it, and tell us like 1 to 2 tests that you would order in this setting. So if you can, I'm going to create those right now. Welcome back, everyone. If you can please put in the chat what you all discussed or what are the tests you want to order. And Dan, would love to hear your thoughts about, at this point in the case, what are you thinking, and what workup would you do next now that we have this infectious workup, maybe persistent fever and negative cultures?
And just before Dan, continue, one piece of information that I think might be relevant is that this patient, because I told you earlier, this patient was having so many recurrent kind of types of infections over the last few months. On arrival with this bacteremia, the transplant team said, let's just stop the tacro and kind of go down on the prednisone. So this patient on arrival was started on ceftriaxone, tacro was immediately stopped, and prednisone was kind of tapered down.
Okay. That's interesting. Yeah, I think at this point, like, can I say with 100% certainty what, specific infection this patient has right now? No. And I think that's often kind of the situation we're in with infectious disease. I'm still saying like fever and something, right? Like what's that other something? And I was hoping that maybe the exam would be a little bit more illustrative, but again, this is the game that we play. It's, we have non-specific fever right now. Can I get any more information on where this fever is coming from the labs? There's not a whole lot of red there on that series of labs. I think maybe the things that could be a little bit localizing are, the LFTs. So you have sort of low positive transaminases, and you have maybe not super duper overwhelmingly positive alkaline phosphatase. Sometimes if you have like a infiltrative or sort of granulomatous process within the liver, you could get a pattern like that, with elevated alk phos and low positive AST ALT. Although this alk phos isn't so abnormally elevated that I'm like, okay, this is definitely the key to this diagnosis. So where do we go from here? I think probably localization will be helpful with imaging, whether that's, just a pan scan, whether that's going to be our TEE, or if you guys end up doing a PET scan or something like that. There's additional information that you gave, Wasim, of like, oh, we've dropped the TAC and lowered the pred. How do we think about that? I think that could raise a couple of different possibilities. One would be, these dynamic changes in your degree of cell-mediated immune suppression could produce something like an iris type phenomenon. So we talk about iris in the context of HIV a lot, of like, oh, they're doing worse with their cryptococcal meningitis despite being on, appropriate therapy after we start the RT. So that's like paradoxical iris, where, the infection and it gets worse when you treat it. The other type is like an unmasking iris, where you're like, oh, shoot, I didn't know that there was an infection there, but now our immune system is pointing to it and telling us where it is. So that would be a consideration there. The other thing that sometimes you see with solid organ transplant recipients with dynamic changes in their immunosuppression is, you could get fevers from just rejection, transplant allograft rejection. So that would be a consideration as well. Regardless, I think both possibilities are going to point us towards getting more imaging to better sense where, what part of the body is being affected by this, or is there like a smoking gun on some sort of cross-sectional imaging or something like that. The other thing that you might consider in somebody who's had like recurrent bacteremias or a lot of sort of bizarre infections, especially maybe in the South, again, I haven't practiced where you guys are, but strongyloides hyperinfection, is that something we need to be considering here with like recurrent GNR bacteremia? Maybe, probably not. Typically you'd see eosinophilia, but the eosinophilia could be depressed by the prednisone. So anyway, I humbly would request cross-sectional imaging of some sort and further workup of endocarditis. I think that would be where I would go first. A couple other just brief points. The white count, you said 17 on admission, down now. Like, okay, sounds good. One of our mentors here says the only two white counts that matter are like above 20 and less than 1. So anything in between then can be, wiggle room. And then you'd mentioned the blood cultures repeatedly were negative after that initial one. That doesn't really dissuade me from thinking about endocarditis with streptococcal species. These are generally pretty penicillin or beta-lactam susceptible, so you could still have a huge vegetation and have negative cultures after antibiotics are started. So maybe I'll pause there, say, I'm interested in whether any specific site like the graft, the heart valve, the liver, is anything gonna, be really our smoking gun that we can then go after a little bit more aggressively.
Yeah, that's great. All like great thoughts. And so we initially, he said he was having this like mild cough that was non-productive along with this fever. So we're like, okay, let's get a chest X-ray. And like most of the times, chest X-ray wasn't like showing much, no acute cardiopulmonary pathology. That was like the report from it. TTE, as you said, also again didn't really show anything. TEE was done, and that TEE showed no vegetations, even though there was some back and forth about that TEE. And Dr. Fatke and I and Yusuf. And so we went multiple times to the cardiology reading room for the echo, but eventually the read or the official view, and I'm trying to remember if we did another TE, we did 2 of them, but it didn't really show. Eventually came back with like no vegetations on the aortic valve or any of the other valves. So we did an ultrasound of the right upper quadrant that showed mild hepatomegaly and some also splenomegaly that was seen on ultrasound of the abdomen, but not much more than that. And then obviously, because there is this AV graft, we did an ultrasound of the AV graft that didn't show really any loculated collection around it, but it did show mild soft tissue edema of unclear etiology at that time. So we did a tagged white blood cell scan, trying to find if there's something. And actually that showed that the AV graft was okay. There was nothing around the AV graft, but it was interesting that it showed that the lungs had lesions that were kind of showing some white blood cell type positive lesions in the lungs. And so where do you kind of go from here? Imaging of the lungs showing some consolidations as well, in the lungs. And at that time, what we decided to do is to do a PET CT. So we decided to do a PET CT scan to try to see what's going on like throughout. And that PET CT read said increased FDG uptake adjacent to the right hip, which that's not somewhere we were really suspecting anywhere clinically. But there was a next to the right hip within the right iliopsoas muscle. There was this increased FDG uptake, centrally hypodense, is concerning for abscess formation per the PET CT read. It did show those multiple FDG avid sub-centimeter solid pulmonary nodules in the left upper lobe and the right lower lobe. And then it showed diffuse FDG uptake in the bilateral dependent lower lobes corresponding to the ground glass opacities and consolidative opacities. And those findings were kind of like new at that time compared to previous imaging. So that's based on that. Then after the orthopedic surgery regarding that fluid collection around the right hip, we called them and they requested that an ultrasound be done and then an aspirate of that fluid to be done, which we did do, and cultures were sent from it. A bronchoscopy was done because of the lung lesions, and that bronchoscopy had the BAL cultures, so bacterial cultures that are negative, fungal cultures are negative, AFB smear negative, but no growth to date. That was kind of like, this was within a few days of it that we're reporting. And then, as I said, biopsy with cytology of this right hip area after the aspirate, they also did a biopsy from it. And that showed no malignancy. And the right hip aspirate was culture, bacterial, fungal, and AFB, no growth to date. So the bacterial and fungal kind of finalized. The AFB was still also no growth to date. AFB and fungal blood cultures were sent at that time as well. And what else? So QFT was positive with a TB1 and TB2 antigens that were mildly positive, 0.6, 0.8, with a good mitogen response. And then, as we talked about, the hemoglobin was kind of going up and down, but the CMV PCR was undetected. EBV was 2,900. Adeno PCR negative, HIV antibody antigen negative. Coxiella serologies were negative. Brucella, somebody was talking about brucellosis initially. Brucella, Bartonella, also negative. Toxo, IgM, and IgG were negative. TSH within normal limit. So that's really kind of like a lot of information, a lot of diagnostics that I kind of brought up now. But okay, I'll leave it now back to Yusuf for kind of
Thank you, Asim. It sounds like the heart was thoroughly evaluated, that was negative. The graft was thoroughly evaluated, that was negative. And we have maybe hip collection, some lung nodules. And we're going to create another breakout room. Of note, the next aliquots will reveal the final diagnosis. So the task for this breakout room is to what you think the diagnosis is and what you would do next. So we're going to take a few minutes only. Welcome back, everyone. If you could put in the chat what you think is going on, or what are the options, or what are your top 3 differential diagnoses that you think is going on, and then I'm going to throw the mic back to you for your reflections and thoughts.
Sorry, my internet booted out for a second. I'm back. Not sure if you asked me a question.
Sorry, that yeah. The question was just like, what are your thoughts and what you would do next, and what is your like top differential diagnosis, basically?
Oh, let me turn off my internet again. I'll be. Yeah, no, I didn't see anything that folks put in the chat, so I'm sure there's a lot of wisdom there. I'm excited to see what people say later on. But in our journey with this case, we've been talking a lot about trying to find some specificity. Is there something to hold on to here? And in the more recent data, we've added specificity. I can't say that I'm going to bet my house on anything quite yet, but I think we have a little bit more to go off at this point. So I think at this juncture would take a pause, take a step back, and say, like, what am I formulating as a problem representation for this? So this is going to be somebody who's immunocompromised, but not so much as she likely was earlier in her post-transplant course, who's coming in with what sounds to be acute to subacute fevers in the context of changing her immunosuppression, with potential sites of disease, including pulmonary nodules that are FDG avid, this abscess in the iliopsoas, some hepatosplenomegaly, although it doesn't sound like that was particularly FDG avid. And then, what appears to be increasing cytopenias, so maybe pointing towards the bone marrow. So taken together, if that was a constellation of symptoms that are all linked, it seems that whatever infectious process, if there is one, is going to be something that's relatively disseminated. So, hematogenous dissemination, and probably involving multiple systems, including kind of the reticuloendothelial system. With the strep sanguinis, that, certainly is hematogenously disseminated, things that we'd be worried about for endocarditis, although we don't have a ton of evidence to support endocarditis beyond just the episode of bacteremia at this point, from our PET scan, from our echocardiography and stuff like that. So I'm inclined to think that even though it's something that could cause a iliopsoas abscess, could cause a lot of different problems, I'm inclined to think that is going to be more of a red herring than the ultimate diagnosis in this case. So then if we reframe to think about, sort of systemic or multi-system affecting infections that can present in something of a subacute manner and be unmasked, then I'm going to go back and say, is there another bacteria that seems to fit? We've done pretty good culture workup for bacterial pathogens. Is there a fungal pathogen? I get the sense that you guys are in more of a histoendemic area than I am. So I would probably send the tests acknowledging that I don't really see a ton of histo, don't have a whole lot of experience. So as a consequence of my, sort of less experience with that pathogen, I would do more testing for it. So like antigens, antibodies, stuff like that. CRAG is an easy test to send. It's never good to be humbled by Cryptococcus. It can do a lot of different things. So I would send a CRAG at this point if that hasn't been done already. And then mycobacteria, you've sort of given a little bit of clues as to maybe a mycobacterial process going on. The quantiferon, I don't put too much stock in that. I think BCG typically doesn't have positive quantiferon, but I'd have to double check that. What you described with the TB1, TB2 minus nil, that would technically be like a borderline response. So in somebody without good risk factors, that's statistically likely to revert to negative on retest. I think it's something to question here, whether they were exposed to TB at some point, or if this is like a newly positive. I might be a little bit more aggressive about treating that as real, but just to say that that's not a smoking gun either. Other mycobacteria, we've talked about M. bovis. So M. bovis is part of TB complex. So it'll come back positive, like on a MTB PCR, or be identified initially as MTB complex. That can take, 2 to 4 weeks, 2 to 6 weeks to grow. So, maybe this ends up being something that comes up positive later on. Could an NTM be there as well? Possibly, I think that the cultures will tell us. And then parasites, I don't think that parasites are particularly consistent with like the information in this case. So I would bet $5, not $500, that maybe this is disseminated BCG infection. In part because, it can be bacteremic, it can cause psoas abscess, it can cause bone marrow involvement, and I think rarely can cause pulmonary nodules as well. But yeah, I'll put $5 on disseminated BCG, not 500. And the other thing I'll say is, if this patient was at UCSF, we would have sent 3 Curious tests by now. So, just to throw that out there, Varun and I talk about that a lot.
Somebody in the comments said, in this economy, Wasim, sounds like you have to send Dan some money. Back to you.
Yeah, so Dan, you kind of win. Seems like you got some money. So this patient's AFB blood was like, brewing for a couple of weeks, and the patient was continuing to have fevers, and all of the other cultures were really pending. And one day it comes back AFB blood culture positive, and it's a MTB complex. So Mycobacterium tuberculosis complex, and as you said, has within it multiple organisms, including Mycobacterium tuberculosis itself, but also Mycobacterium bovis. And after we did really sequencing on it and testing on it, it came back as actually BCG. So it was the BCG itself that was sent. And here I want to say that one of the things that I kind of like learned from this case when I was reading about it and like presenting it is that a BCG that was used historically for the vaccine for people throughout the world is not the same BCG that is given to people in the US so there is like some engineering differences that might explain why the quantiferon could have been positive in that from that BCG, or mildly positive from that BCG, and what usually is not positive from BCG that is given just for vaccination. But yeah, this patient had disseminated BCG from intravesical BCG treatment for his bladder cancer.
Wow.
So yeah, you kind of thought about it from the beginning, you kept your mind open, and then kind of like had on it. So yeah, that was what it was.
Wow. Yeah, BCG is an interesting one, or Mycobacterium bovis is interesting. For folks in the audience, you might have seen it and stuff at some point, but it's intrinsically resistant to pyrazinamide. So some of the testing's a little bit different. Or some of the treatment regimens are a little bit different. Like you can't use a PZA containing short regimen for it. You often see, wild type M. bovis in folks, often from other countries like Mexico and Central America, where it's, one of the cattle associated infections you get from like raw milk. And as a result of it being like a foodborne sort of thing, people tend to get more extrapulmonary disease. So yeah, I had one clinic day where I had like 2 M. bovis adenitis cases like scheduled back to back. And I was like, oh dang, this is pretty nuts and stuff. But that's one of the other sort of subtle differences. It often causes more extrapulmonary disease.
Yeah, and M. bovis itself should cause a positive quantiferon, by the way, in comparison to BCG, where it should not, in general, at least once for vaccine. All right, perfect.
Thank you both so much. If anyone is interested in presenting a case, you can sign up on the link I said online. Varun, throwing the mic to you for your reflections and thoughts. Can't wait to hear.
Yeah, thanks, Yusuf, and thanks, Dan, for that amazing discussion. And no surprise to me that you got the correct diagnosis. My reflections on this case are primarily sort of reflecting on the systems factors that influence our reasoning and how hard it can be to escape them. The first is when I inherited this case, it was signed out to me as a case of strep sanguinus infection of the AV graft. You must convince the vascular surgeon to remove the AV graft, which is why actually a tagged white cell scan was performed first to answer that question in the chat, because that scan was requested by the vascular surgeon to exonerate the AV graft from having to do a surgery. So that was my first sort of takeaway, that so much of our reasoning is shaped by the way the case is framed to us. The second takeaway is that we ordered an AFB blood culture on this patient the day that we took over their care, and it took 29 days for the culture to turn positive. And for every single one of those 29 days, the patient was febrile. And it is very difficult to sit on your hands and wait for an AFB culture to turn positive. And that is one of the challenges of these clinical problem-solving sessions, is that they cannot replicate the difficult task of waiting for diagnostics to come back. And in those 29 days, the patient had innumerable tests, including 2 TEEs, a PET scan, a bronchoscopy, an iliopsoas abscess aspiration, bone marrow biopsy, innumerable blood cultures, every single serologic test known to man, including the ones you see here. So that is a challenge of reasoning, right? It's hard to watch a febrile patient and not have the answer. And this is just one of many cases I've had where diagnostic test turnaround time is just an intrinsic feature of having to wait for challenging cases to reveal themselves. The third lesson I had was, and Dan alluded to this at the beginning, is that the traditional illness script of disseminated BCG is presentation in the first 6 to 12 months after installation. And this patient's presentation was like 15 to 18 months later. And I had the same intuition when I saw this patient, and so lowered that on my differential diagnosis as a result. And it's a reminder to me about how our illness scripts are deficient in immunocompromised hosts, and why we sort of have to maintain this broader differential and not adhere so tightly to sort of prototypical illness scripts when we encounter these patients. Because I've seen very similar patients like this that end up with, disseminated nocardiosis, and it came out of nowhere. So those are my 3 lessons from this case that I wanted to just share.
I think that's such a great point, for it's very different in like a case context too, because you get a sense of like what's been sent but not fully resulted, and what's an interesting case to present and stuff. And it's very different than true life, where people are saying like, we got to get the graft figured out, or it's obviously strep sanguinus and you get a sign up from somebody. So but yeah, Wasim, thank you so much for presenting this. I mean, sounds like I learned a lot from this case. It sounds like your team definitely learned a ton as well.
Yes, we did. Thank you for being here, for all the teaching.
All right, I want to give another big shout out. Thank you all for coming and participating. I also really want to thank again all of our facilitators, our presenters, our expert discussants. It's been an awesome experience setting up this case conference, and we're thrilled and looking forward to doing more in the future. Before we exit out, just wanted to put up a survey. We wanted to get some feedback. This is, again, our first case conference of many throughout the year. And we are a new group kind of fostering a lot of these discussions and projects. And so we would love some feedback. It takes literally 2 to 3 minutes. I understand some folks are driving or on service. And so no pressure. We'll be sure to send this out as follow-up after this case conference. But thank you again for attending, and we look forward to having more discussions in the future. And I hope to all of the ID fellows, I hope you're hanging in there, and best of luck with the start of the new academic year.
Yeah.
I'll keep this up for just another minute or two before we close out.
Good luck for everyone applying for residency and for fellowship. And also thank you for Sarah Blaine for scribing this case and like keeping everything clear for everyone who has participated.
All right, I'll leave this up for just another minute, and then feel free to log off, and then I'll close out the meeting in just a minute or two.